You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 7th, 2019. This week I'm talking PCI complications, health hubs, TAVR, VTE prevention, and how belief does not make something so in science. The first topic today are the risks of elective PCI. We do it often. We do it through the radial artery. Patients can get off the table, walk out of the lab with a mere Band-Aid on their wrist. These facts about PCI make it easy to take it for granted that putting stents in coronary artery comes with potential harms. A new registry study from Europe has identified surprisingly high rates of unexpected cardiac arrest and death in patients having elective, emphasis on elective PCI. This was a paper presented at the EuroPCR meeting, and it included more than 113,000 elective cases at high-volume centers. 330 patients had cardiac arrest, and of these, 162 patients died on the table or during the first 24 hours from elective PCI. To me, this is remarkable, since these were all patients who would not have died if we did not do the procedure. Also remarkable was that this registry excluded high-risk patients such as those who've had STEMI or out-of-hospital cardiac arrest. Now, I know what you may be thinking. Come on, Mandrola. These patients had to have this procedure done, and no procedure is free of risk, and many of these patients would have died without the intervention. Well, the problem with that logic is, one, we have tested PCI for stable coronary disease and found that it doesn't reduce MI or death, and two, the benefit of an early invasive approach to STEMI or unstable angina is real, but these benefits are small, and I strongly believe that many patients with ACS could be stabilized and at least an attempt made to discuss or think about a conservative or delayed interventional approach. Instead, at least in my area, we have conveyor belt medicine in which any troponin rise equals a cath or PCI. Now, an aside here, please read one of our new contributors, Dr. Jaya Malidi, an interventional cardiologist who's written a beautiful piece about the downsides of algorithmic, unthinking medicine called conveyor belt medicine. I highlight this European registry study because thinking about the risks of elective procedures cannot be emphasized enough. Yes, of course, the average risk of elective PCI is low in absolute terms, about 1 in 344 cases. But as the mathematician and writer Nassim Taleb teaches, the risks here are asymmetric. As doctors who do procedures, we mustn't think only of the chance of complications, but also the consequences of it. And one final note on this study, good on EuroPCR for featuring this important study, and good on our news team for covering it. Second topic today is about health hubs. CVS, a large brand of retail pharmacies, and one of the U.S.'s largest pharmacy benefit managers, announced it would offer expanded health services in up to 1,500 stores. Now, you may be wondering what exactly is a health hub. The new format includes an employee with the title of, quote, care concierge, who will direct customers to health services such as a nutritionist or nurse practitioner. CVS will also offer screenings for sleep apnea and ophthalmology issues related to diabetes, among other services. CVS said stores that have these health hubs experience more foot traffic, front-of-store sales, and prescriptions dispensed. And I highlight this move because it so perfectly highlights the core problem with U.S. healthcare, and that is that our system is decidedly supply-dependent rather than demand-dependent. Now, normal economic principles suggest that demand should drive. In U.S. healthcare, this does not hold. Rather, it is this: if you build it, they will come, whether or not it delivers health. And sadly, for the health of Americans, healthcare continues to be an engine of our economy. Now remember, The medical conservative does not oppose private enterprise, capitalism, or the accumulation of wealth. Instead, the medical conservative opposes medical progress and the accumulation of private wealth that accompanies it when it occurs under the pretext of science without meaningful improvement in patient outcomes. Here, it is a total farce to think that a care concierge at a drugstore will have any impact on health. This is simply the pretext. The real text here is that health hubs will increase foot traffic, front-of-store sales, and prescriptions dispensed. And make no mistake, my criticism here is not on CVS. As a corporate middleman in a system that allows corporate middlemen, they are acting as any profit-driven company would. I think the fault here lies mostly on us, the medical profession, for being complicit and silent on a healthcare system that is so ineffective, wasteful, and unjust. Third topic today is heart block after TAVR, or transaortic valve replacement. The University of Colorado investigators have published useful observations on the occurrence of heart block late after TAVR. This is an important issue because of the push for early discharge after TAVR. Now remember, after surgical valve replacements, patients stay in the hospital for 5 to 7 days, which is often enough to catch late occurring AV block. So the University of Colorado team decided to use ambulatory ECG monitoring, which can be done in real time. In other words, if a Brady or tachyarrhythmia meets a set threshold, say a 5-second pause, the care team is notified. Now, while I don't like using these sorts of ECG devices that notify the on-call docs of arrhythmia in stable outpatients, say with AFib or other benign arrhythmias, in these patients I prefer patch electrodes that are not connected to real-time monitoring. But post-TAVR patients are definitely at risk of serious complications when AV block occurs, so it's good to know and have people notified. So this brief but useful report published in JACC found that delayed high-degree AV block occurred in about 1 in 10 patients at a median of 6 days, ranged 3 to 24 days after TAVR. Of course, right bundle branch block was a predictor of AV block. Obviously, if your right bundle branch is blocked, the valve squishes the left bundle branch and AV block is likely. I highlight this study for 2 reasons. One, it is a good illustration of the benefits of collecting data on your own experience. Second, it highlights the important finding that high-degree AV block after TAVR is a problem worthy of further study and heightened vigilance. As a longtime implanter of pacing devices, I think the downsides of creating a need for pacers is underappreciated, especially as TAVR expands to lower risk, younger patients. Next topic today is VTE prevention in post-op patients. Now, researchers from the University of Utah published a small but interesting study on preventing VTE in patients who have had colorectal surgery. They asked a simple question that I've often wondered a lot about. It is the commonly used drug 40 milligrams of enoxaparin enough to prevent VTE? And they note as background that between 4 to 12% of patients who have colorectal surgery have a VTE despite using enoxaparin 40. Now, this was a non-randomized study of only 116 patients in which the investigator measured anti-factor Xa activity levels in response to a dose of enoxaparin. Patients whose anti-factor Xa level was out of range entered the trial's intervention arm, where real-time enoxaparin dose adjustments and repeated measurements were performed. And the researchers found that among 106 patients with appropriately timed anti-factor Xa levels, a marker of the extent of anticoagulation, more than 2/3 of patients received inadequate anticoagulation. They also report that patient weight, high weight, and peak anti-factor Xa levels were inversely correlated. They also report that nearly 80% of patients had a trough anti-factor Xa level that was not detectable. They found that real-time enoxaparin dose adjustments were effective in achieving an in-range peak level of anti-factor Xa activity. Now, their conclusion stretched it a bit. They wrote that their study supports the finding that most patients undergoing colorectal surgery receive inadequate prophylaxis from enoxaparin 40 milligrams once daily. But the accompanying editorial rightly took the authors to task. The editorialist wrote that the author's conclusion is not supported by their findings because the 90-day VTE rate was not different between patients with low or normal in-range anti-factor Xa levels. So I highlight this study for a number of reasons. First, while it is potentially important to document that low-dose enoxaparin results in low or very low levels of anti-factor Xa activity, it's crucial to remember that anti-factor Xa activity is a surrogate outcome. The real outcome is VTE rates. This study, however, does make me wonder about doing a proper trial looking at enoxaparin dosing and perhaps dose duration. This could even be a pragmatic trial in which you randomize by day or week or center, then look at outcomes. VTE prevention is important because when it occurs, post-op VTE is an iatrogenic harm. In other words, we caused it. And when we intervene on patients, it is incumbent on us to study the ways to make interventions safer. And remember, VTE prevention with anticoagulation does not come free. It comes with a risk of bleeding, so just simply increasing doses of anticoagulation may not be the right answer. Finally, I think we underappreciate the uncertainties of plasma levels when we use anticoagulation drugs such as enoxaparin or DOACs in patients with obesity. The final topic today is a doozy. The general topic is rivaroxaban for patients with heart failure and sinus rhythm. And I'm going to close with a study presentation at a major medical meeting that deserves serious criticism. Dear friends, you must keep your skeptical guard up at all times. This question concerned prevention of embolic events in patients with heart failure with reduced ejection fraction. Remember, patients with bad ventricles have stasis and low flow. Thrombus from cardiac sources, therefore, is plausible. Also plausible is the use of oral anticoagulants to prevent this. It makes perfect sense. So sensible, in fact, that the makers of a DOAC wisely paid for a trial testing rivaroxaban versus placebo in patients who had heart failure. They called this the Commander Heart Failure Trial. It was a large, multi-center RCT published in the New England Journal of Medicine last October. They had a legitimate primary endpoint, which was a composite of death from any cause, MI, or stroke. The principal safety outcome was serious bleeding. And here was the bottom line of the original Commander Heart Failure RCT. It was that rivaroxaban at a dose of 2.5 milligrams twice daily was not associated with a significantly lower rate of death, MI, or stroke than placebo among patients with worsening chronic heart failure and reduced ejection fraction, coronary disease, and no AFib. I will also add about the main Commander heart failure data that all-cause mortality was no difference, bleeding, no difference, and the subgroup analyses, which found no subgroup that benefited from rivaroxaban. Nary a signal of benefit here. Then, at the European Heart Failure meeting, in a featured late-breaking clinical trial session, we get to hear a post hoc analysis looking only at one of the components of the primary endpoint, or stroke. The post hoc study found, yes, rivaroxaban reduces stroke. Only, you cannot do this. I went back and I looked at the main table of the Commander Heart Failure results in the New England Journal. There were about 630 primary endpoints in each arm, rivaroxaban and placebo. Stroke represented the least frequent of the components of the primary endpoint. It was like 51 versus 76 in the rivaroxaban and placebo group respectively. So a small fraction of the events were stroke events. Therefore, not only are the investigators analyzing one of the three composite endpoints from a negative trial, after having seen the data, they were analyzing the one with the least number of events and thus most likely to be spurious. Remember, the reason cardiovascular trials use composite endpoints is to have enough power to see signal in the noise, and you lose all that when looking only at one type of event. Preventing embolic events in patients with heart failure is indeed an unmet need, but post hoc analyses of decidedly neutral trials is not the way forward. In science, believing something works does not make it so. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to write a review, give us a 5-star rating so that other people can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.